It's a pleasure to be here, and thank you all for being here. So, before we go into today's presentation, you may be wondering why I have a doctor on that slide as the picture on my first slide. And the reason is that doctors like ourselves, helping professionals, people in this industry, we're the prototype of what I'm about to talk about. We're the ones at risk of having these common but unknown indicators of depression. And I'll explain to you why as we go along. So the objective of today's presentation is to increase awareness of these common but unknown, informal, that's why I use the word indicators. So they're not symptoms, they're symptoms, but they're not formal symptoms, meaning that they're not recognized by the DSM-5, which is how we classify mental health disorders. But they're symptoms nonetheless. So I use the word indicator to differentiate them from formal symptoms. So to increase awareness of these common indicators and that are unknown, and also to help ourselves. So if you're aware that these are indicators of depression, then you would be able to recognize them in yourself, and then you would self-present and to reduce unnecessary suffering and improve your quality of life. So I'll be using this outline. I'll start with an introduction, I'll mention statistics, I'll define depression according to DSM-5, talk briefly about risk factors and causes, then we'll listen to a patient's perspective. So that it won't be me talking, you listen to a video of a real patient explaining what it feels like to have depression. And then we'll go into the real topic of today, which is what are these common but unknown indicators of depression, and what to do, and then I'll conclude. So we'll start with introduction. What is depression? So depression is a serious mental health disorder, different from sadness. So when you hear people say, oh, I'm so depressed, it's not the same thing as the clinical diagnosis of depression. Depression means, from a therapeutic point of view, that people begin to see the world negatively. So it affects how someone thinks about themselves and other people, it affects how they feel, and affects what they do. It virtually affects the way they see the world. This is according to the APA, American Psychiatric Association. Most importantly, it severely reduces their quality of life, the kind of enjoyment they have from being alive, and their functioning. Remember, doctors are the prototype, and we're talking about people helping others. We are the ones who help other people. So imagine if you are compromised by something as serious as that. So according to the WHO, the way things are going in terms of how common depression is, by 2030 it could well be the most common mental health illness that exists. So right now it's anxiety, generalized anxiety specifically. Generalized anxiety disorder is the commonest mental health illness that exists. But according to WHO, by 2030 we might well be seeing depression coming out on top. And apart from affecting quality of life, it significantly contributes to the burden of disease. That's the number of people suffering in this world because of depression. So I want us to realize that depression is one of those diseases that has like a chameleon-like presentation. We all think we know depression, sad, withdrawn, not engaging, but I'm here to tell you that a lot of times this is not the case at all. And that is why these symptoms, though common, are unknown, because the idea we have of depression is different than actually what it could present as. So the symptoms that we see in Africa, it's been found to be a bit different from what happens in the Western world. So around these parts, we have a lot of somatization going on. We have a lot of psychological symptoms like sadness, anxiety, being, converted into physical symptoms like actual, that might mimic neurological presentations. Interestingly, in my clinic these days, I'm seeing a lot of functional neurological disorders. Yesterday, I saw a patient with psychogenic non-epileptiform seizures. So someone presents with something that looks like a seizure, and it's because of sadness and intense anxiety. Someone presents with something that looks like a stroke with facial deviation, and it's not a stroke, it's not a Bell's palsy, it is sadness or anxiety. So this is just the tip of the iceberg. We're getting, we'll soon see the other symptoms that are common, but we don't know them. We doesn't speak depression when we see them. That's the point of this presentation. So symptoms differ also. Another reason why it's common but unknown is because it shows up differently if you're a man or you're a woman. And another reason why it's common but unknown is because people have these symptoms I'm about to mention, and they attribute it to something entirely different. When I was a resident at National Hospital, the senior registrar, there was a patient I saw, a doctor, a colleague of mine. Being in family medicine, you see everyone, including your own colleagues. So she came with fatigue, loss of energy. So we screened for malaria, we looked for anemia, we looked for all sorts of things, pregnancy, and there was nothing wrong with her. Kidney dysfunction perhaps, liver problem perhaps. So we did everything we could, even gave her, supplements, gave her ginseng that builds energy, and she wasn't getting any better. So eventually we had to send her to see the consultant. And later we went to the consultant to say, why was she so tired? And it turned out she was depressed, and she did not know it herself. Another example is not too long ago. So this first example happened many years ago, but this happened December. So a family friend of ours, a man, so he comes and says, I think I'm stressed. I'm going through a lot of stress at work. Things have been busy. I get feedback from my wife and my kids. I'm irritable, easily angered, easily annoyed. I can't take what I used to take before. Low frustration tolerance is what I said to myself. So when I asked him some more questions, it turned out that he was dealing with depression. So this is just examples of what we're talking about, that it presents in ways that we don't quickly recognize as depression, and in people who are otherwise high functioning. And this is why doctors are the prototype. We invest a lot of our time on our patients, on our work, and we don't pay so much attention to ourselves. And even society doesn't expect us to have depression, for goodness sake. We are the doctors, aren't we? But that is the more reason why these symptoms are unknown to us, because it's not expected, and it's not congruent with who we are and how we see ourselves as the helpers. And this is the reason why it thrives amongst us, and we don't even know what is going on with us. So hidden depression. This is not a formal term. It's not in DSM-5, but it's been used to describe depression that is not easily recognized. Exactly what I'm talking about. Hidden because doesn't present with typical symptoms. Sadness, low mood. The person is meeting their responsibilities. They are coming to work on time. They are taking care of their, family. So we also know this kind of depression as smiling depression, similar to, and walking depression, similar to walking pneumonia for the doctors amongst us, where you have pneumonia or someone seriously ill and they're walking around. Reminds me of COVID. We had someone with severe COVID and the chest is riddled with white opacities, and the person is going around until suddenly you see a precipitous drop in the oxygen saturation and the person is gone. So same thing. Person seems to be doing okay, seems to have their act together. Next thing you hear, they're dead. And this brings to mind a colleague of mine where I used to work who committed suicide before our very eyes. What I mean by before our very eyes means he walked the same corridors with us, we ate in the same cafeteria, and then we heard he had killed himself. So this is hidden depression, and this is what I'm talking about. That it can present in ways you don't expect it to. So you don't see it coming, and even in yourself and in your colleagues. And by the way, doctors have a high rate of suicide, just so you know. Another type, still talking about introduction, is high functioning depression. Now, these are examples of atypical ways that depression presents. So I'm trying to disabuse your mind from the typical picture of someone who is sad, depressed, withdrawn, not being able to meet up with their responsibilities. So these things still happen. Depression, by all means, still presents that way. But in some people, especially high-functioning professionals, especially people for whom it's unacceptable to see themselves in that light, we do everything to maintain that veneer of happiness while we're collapsing inside. So high-functioning depression is depression that happens in people who are able to still meet deadlines, carry out responsibility, while still maintaining the mask of, having everything together. Now, it's not necessarily that people are trying to be deceptive. It is that they don't recognize it in themselves. So even in session, when I tell someone that, this is what is going on, they are shocked and they think for a while, and then a lot of times they're like, you're right. Because part of what I see myself doing, I work very hard. This is just an example. I work very hard. It's not necessarily because I am so dedicated to my job. It's because I don't want to be alone to feel the way I feel. So when we have that conversation, it dawns on them that some of the things they're doing is actually being done to cope with how they're feeling. So what are these indicators of depression that I'm talking about? They are not listed in the formal DSM-5, but they have been definitely associated with depression. And I think why they're not listed is because they can also signify other things, anxiety being top on the list. So just so you know, depression and anxiety are like brother and sister. They're like hypertension and diabetes. They love to go together. So a lot of times it's either one leads to the other. Someone is so depressed and they're anxious about how they're feeling, or they're so anxious that they become depressed because they can't do anything about being anxious. So statistics, about 300 million people in the whole world suffer from depression. That's according to WHO. And there's been an increase between 2005 and 2015 in the number of people that are depressed. And this is why, like I said earlier, that WHO extrapolated that by 2030 it would be the leading mental health illness in the world. In Africa, we have about 30 million people who are depressed. So this is contrary to what we say. It's a myth that the black man doesn't have all these things. We are too, we don't deal with emotions. Not so. It affects us just as much. In fact, I think, and you might agree with me, that this figure is a gross underestimation. I think that we have way more depression than we like to admit. So in Nigeria, we have over 7 million people. In my clinic, most of my patients, either as a single disorder or as a comorbidity, are struggling with depression. So it's commoner in women. Now, this might be because women tend to be the ones who like to talk about how they feel. They like to get help for how they feel. They are in contact with the health care system more than men. Or it may just well be that women really do have it more than men. But unfortunately, less than 10% of people who have these difficulties actually get the care they need. Sadly, I've seen someone come to see me and said, while she was trying to get help for depression, seeing a therapist elsewhere, that the therapist wanted to be involved with her sexually. So, imagine that experience, horrible experience, and then somehow found her way to me. So according to DSM-5, this is what makes a criteria, this is what makes depression a diagnosis. This is what the criteria that need to be met for you to have a diagnosis of depression. Low mood, loss of interest, loss of concentration, low energy, significant and unintentional weight loss, insomnia or hypersomnia, psychomotor agitation or retardation, which means that the person just can't seem to sit still, or the person is not able to, they're physically slower than they used to be, and they're thinking slower than they used to think. So it's the psychomotor, so in terms of their movement and their thinking is slowed. So, and then feeling of worthlessness, guilt, thoughts of death. So this is what we mostly recognize as depression. So I'm here to tell you that there are a lot more than this, and they're actually quite common, but we don't know them to represent or signify depression. So before I continue, depression could be single episode, it could be recurrent, it could be persistent, it could be unipolar, it could be bipolar. You can accidentally be treating bipolar disorder and you think it's depression. So when you give the antidepressant, it actually leads to the manic episode coming. So you need to be careful before you make that diagnosis of unipolar depression. And just as by way of emphasis, depression is not the same as sadness. So I'm going to have this brief discussion here just to clarify, and this is what I tell my patients all the time, either the first or the second session, because I want them to clearly know what constitutes depression, so that when they get better, they would, and they go back, to doing what they're doing, they would clearly know when they're having a relapse or when they're just sad, which is actually a part of life. Depression is not a part of life, sadness is. So sadness is when you have low mood because of something happening externally, external situation. So we all can identify or relate times when we've been sad about something. Depression, however, is persistent low mood that has nothing to do with the circumstances. So something happens that you should be happy about. Maybe you're happy for a few minutes and then you go back to being sad. Something happens that you should be excited about. You're excited for a few minutes, but then the sadness still really lingers on. And the reason for that is because of activated core beliefs, activated negative core beliefs. So a core belief is the basic way we see ourselves. So we all have positives and negatives. So a core belief could be something like, I can cope. No matter what happens, I can handle it. I'm strong, I'm independent, I'm intelligent, I'm an achiever. So that would be a positive core belief. A negative core belief would be something like, I'm not good enough, I'm alone, I don't fit in, something is missing, I'm different, I don't measure up. So when someone is depressed, it's because the core belief that is dominant at that time is the negative one. And what happens is it's like someone wearing dark glasses. So the dominance of that core beliefs makes the person see everything else in a negative light. It's like coming somewhere that is bright and you're wearing sunglasses. Whoever is in the bright place can argue themselves hoarse, telling you that it's bright, but to you it is dark. And as long as you have that glasses on, the effect of that negative core belief, it is dark to you. What people that are depressed don't know is that that is their perspective. That is their own perspective, not the entire picture. So where we come in as therapists is to begin to show them that just because you failed in this aspect, for instance, does not equate to you being a failure. And this idea that you're a failure is an opinion, not a fact. And when we begin to show them that it is your perspective and an opinion, an idea, not a fact, that's where the healing comes in. So what are the risk factors for having depression? Being female is a risk factor because it's 2 times commoner in females. Having a family history is a risk factor because there's a genetic component, and children learn by watching their parents. The behaviors are modeled by parents to children. So if you deal with anxiety by pacing up and down, by panicking, you teach your kids that when things are uncertain, I panic, I pace, I shake. But so it's not only genetic, it's not only through inheritance that people get depression. Sometimes it's modeled behavior and things that are seen as what children see growing up, because these are the times when the core beliefs develop when we're growing up. So childhood experiences, negative experiences, losing a parent before age 11, negative home environment, mentioned genetics, recent stressors, lack of intimate confiding relationships, low socioeconomic status. So these are risk factors. They are not direct, they don't directly cause depression. Even the genetics is a risk factor. You might have a family member, a parent that was depressed or who is depressed. It doesn't mean that you must be depressed. It just means you're at risk. And when the puzzles fall in place, when given the right circumstances, with you reacting a certain way, depression will be the natural consequence, but it's not directly related, just so you understand. Now, talking about symptoms, how does it feel to be depressed from a patient's perspective? I'd like to introduce to you someone you will probably know very well. This is Ms. Taraji P. Henson. This is a popular actress, a Black American actress who has won multiple awards. It might surprise you to know that she was battling with depression not too long ago during COVID 2020. She's much better now. Now, this is just again to present to you that this myth of it's not, I'm successful, I have everything going, what could I possibly be depressed about, is false. It has nothing to do with externals, like I said, when I was trying to differentiate sadness and depression. It has everything to do with the way you see yourself and the whole world. So, audiovisual, could you please play the video? So rather than hearing it from me, let me...
I struggle with depression and anxiety. I would have to say I realized it about 2 years ago. I noticed the mood swings, like, one day I'd be up and the next day I'd be down, feeling like I don't want to go out in public, almost agoraphobic, like, ugh, too much to deal with. feeling really awkward in my skin, feeling out of sorts, and just down, like Debbie Downer, like a dark cloud. And then there would be days where my brain wouldn't stop racing, I would think of the most worst scenarios in the world, which would heighten my anxiety. And, people were like, you just need to meditate and yoga and things like that. And I would do that, but my brain would still race. For me, there was no shame when I started to recognize it. It was like, I have to get some help because I'm the life of the party. And when I go dark, I go dark. I don't want to leave the house. And my friends started to notice me pulling back. And my father, who also had his issues with mental health, was really open about it, about his manic depression. But, as I think back, no one else really talked about it. It was hush-hush, or, he just crazy, or, things like that. But my dad, what he needed was a culturally competent therapist. And it's not even about the skin color or the race. It's about being culturally competent. And the reason why we can't find culturally competent therapists is because at home, in the African American community, we don't talk about mental health. It's a stigma surrounding it. And when you have no one to talk to, what a person usually do is they will try to self-medicate. We're just not allowed to be vulnerable. We have to be strong all the time. This is 400 years of damage, 400 years of trauma that we have not dealt with. And the way we deal with it is be strong. Put on a strong face. Nothing's wrong with you. You don't have mental health. You're not gay. You're not allowed to be human. That's a lie. We hurt and we're suffering. When you think about the trauma the African American community has been through since we've been brought to this country, we have not dealt with that. And then you get to these microaggressions that are happening right in front of our faces every day on television. Women's sons are being taken from them for no reason at all. And through that, we still have to be strong? How fucking dare you? How dare you? How dare you put that on me? I felt pressure to be strong as a black woman in Hollywood because I kept hearing that term. Everyone kept saying, we're strong black women, strong black woman. Then I realized that's a myth. It means that I'm some superhuman in some kind of way where nothing affects me, and that is so far from the truth. Sometimes I don't want to be strong. Sometimes the weight is just too much, and to put on that facade like you're strong all the time, it's exactly what it is, a facade. That's whack. You have to be human. And human means you're vulnerable. And human means you're layered. And being in an industry where, you're getting paid 52 cents on the dollar compared to a white male, things like that weigh on your soul, because I'm an artist, and I'm an artist to the bone. So when I work, I give you all of me. And to know that all of me is only worth 52 cents on the dollar of what he's getting paid, that hurts. A lot of that stuff started weighing on me and sort of like dimming my light, and I had to just get control of it. And what I started to do was started making me feel good about it, is not keeping it in and talking about it, because if you talk, maybe things will get fixed. I felt such a relief when I finally said it publicly. Like, I suffer from this. People it was an outpour. It was an outpour. People, it was like they were like this, and all of a sudden they felt free to speak on it. When I got back above water, when I stopped suffocating myself, I was drowning. And once I released my truth, once I spoke my truth, I started to float back. That's what it is. It's luggage, it's baggage. And it will weigh you down. You better pop those trunks and get that mess out and deal with it. It's okay. We're human. No one's perfect. The perfection is the perfect lie. When my therapist said that, my wings sprouted. The pressure of trying to be something perfect which doesn't exist is crazy. Let go of that myth. When I'm vulnerable, or I'm scared, or I'm having these non-pleasant thoughts, I let it run. Because if you muffle it, it's only going to resurface again. So you have to kind of let it run and play out like a faucet. Just let it run until the water runs out, and then you pick yourself back up. Because your mind will play tricks on you. I talk to myself, and I think more people need to talk to themselves, because you work things out. And it's not, people can call it crazy, whatever. I gotta catch myself doing it in public, and I have to stop. But it's just a way to work things out. It's okay. It's okay. I will have a full-on conversation with myself in the mirror. When you have issues and you have no one to talk to, and the walls are closing in, and the voices are getting too loud, what I notice is people will start to self-medicate because you want to feel good, right? So then they turn to alcohol, they turn to drugs, and we're seeing this with the youth a lot. I'm a celebrity, and at this point, everybody kept asking me, do you have a charity? And I really couldn't find anything that I was passionate about, and then I was like, this is it. You know what I mean? Because this is something I'm really passionate about. This is something that is a necessity for me. And so we have to break this cycle of keeping our mouths closed. So I called my best friend, who also has a lifetime of suffering with anxiety, and that's when we decided to birth the Boris Lawrence Henson Foundation, named after my father. So I think he'd be really proud. I felt such an urgency to do something. I felt like it was my mission to give back to these children because they're having coping issues. And so my foundation, what we're trying to do is we're trying to get these babies while they're kids. So we infiltrate the school. We get counselors in there who can see a child dealing with a traumatic situation at home, because these kids come to school from trauma, from traumatic situations at home, and we expect them to learn, to sit down and focus. I'm speaking up now because we are facing a national crisis. I want people to know that it is okay to seek help for mental health. There is nothing wrong with it. You go to the dentist, don't you? You go get your yearly checkup, gotta check on your mental.
So, do I need to say more? So, I hope that hearing it from someone who is a professional, accomplished, successful, makes it hit home more than just what you've been hearing and you might have been hearing. So, she is a prototype of professionals who are struggling with difficulties with their emotions. And I want to just point out some things from what she said. So some of the way she felt overwhelmed, she kept thinking the worst. She had typical symptoms as well, like social withdrawals, and people did not even recognize that she was dealing with what she was dealing with. And so they offered meditation and yoga, which she tried, and it didn't work. So it seems like she went through a lot before it dawned on someone that, oh, why don't you go get help and, see a therapist or a doctor or something. And then remember when we talked about family history, so her father had manic depression, also now known as bipolar. And, it's not just in Africa that there's mental health stigma. There's still stigma even in the Western world. And this facade, this tightrope that we're trying to walk, where we feel like we should be a certain way, societal expectations, cultural expectations, is huge on men. I think even more on men than women, because women are allowed to be vulnerable. We're allowed to cry, we're allowed to rant, we're allowed to vent, we're allowed to complain and be the soft ones. But for men, I find that it's even more difficult. So with this hidden depression I mentioned earlier, the people I've seen with it are actually more men than women, because it's almost like they don't know who to turn to. They can't talk to their wife because they are the pillars, they are the support. She comes to them. How would it make them look if he began to fall apart? So there's a lot of pressure on people out there, especially men. And what I'm trying to say is that even if you feel that way, that you have expectations to meet, and you have to be a certain way because of society and the role that you're playing, it's impossible. No one is perfect. No one has it good all the time. Everyone has strengths and weaknesses. No one is strong all the time. So it's a good idea, and it's normal, and it's part of being human to get help if you feel that you're not meeting up, or you feel that something about you is different. But we'll come to that. Let me not jump the gun. So let's get to the crux of today's presentation. Common but unknown indicators. What are these common but unknown indicators? Chronic procrastination. So I use the word chronic. So if you're procrastinating about something and you're not generally a procrastinator, doesn't mean you have anything wrong with you. But when you find that it's how you cope generally with everything, it's affecting every aspect of your life. It's at home, you procrastinate. At work, you procrastinate. With your kids, you procrastinate. Then you might need to look a bit deeper. It might be just more than just procrastination. So why would this be an indicator of depression? Because remember, we looked at the DSM-5 criteria. Loss of energy, difficulty with decision making, difficulty, concentrating. When these things are put together, the result is I can't do it. And then you procrastinate. It's too much. So the conclusion or the aftermath of all these symptoms that are listed by the DSM-5 is that you don't want to address what you need to address. And then you say, I'll do it tomorrow, and that is procrastination. It could also be an indicator of anxiety, and it could actually also be a sign of ADHD. But we're talking about depression. That chronically procrastinating in all or most aspects of your life is suspicious of depression. The next symptom is the fatigue or low energy. Now this is, quite common. A lot of times when we're tired, we think, malaria, we think anemia, I'm not eating well, I'm stressed. We hardly think depression. And actually this is a formal symptom. It's not even an indicator, it's a full-blown symptom according to DSM-5. The problem is we attribute it to mean other things, like the things I've said. And the reason we do this is not just because, why would I be depressed? I'm a doctor. Why would I be depressed? I'm a successful whatever you are. But because it's unacceptable, we can't, it's not compatible with our self-image. This is the most common reason I've seen in therapy. It just doesn't go with the way you see yourself. I am strong. I'm not weak. I'm not the kind of person that has depression, doctor. I am competent. I'm independent. I'm not the kind of person. I'm not that. But the truth is, like she said, Miss Taraj, that no one is strong all the time. It's okay. It's okay. You wouldn't blame someone for coming to see you with a cold or malaria or hypertension or whatever. You would treat them the same thing. Irritability. In the example I gave earlier with the family friend, he was speaking of irritability, not being able to handle things he was able to handle before. Being easily annoyed, yelling at his kids, shouting at his wife, easily provoked. And for the life of him, he didn't see depression coming. He spoke to me just for me to give him, maybe he thought I was going to tell him, oh, maybe let's do some tests. So when I started talking in the line of mental health, he was like, are you serious? And then I sat him down and we had a talk, and, hopefully he'll get the help he needs. So feeling easily frustrated, angry, impatient is a common but unknown indicator of depression, especially in men. It's actually recognized formally that where women might present with crying or low mood, men typically show up with irritability, and it's the same as because of underlying depression. Another common but unknown indicator of depression is being a workaholic. It's almost like a feather in your cap when you say, I'm just a workaholic. It's just me. It's just what I do. But sometimes the work is you escaping how you feel when you're alone. So people engage themselves with things. You're here, you're there, you're busy all the time. It's not only always just because you love what you do. It may also be because you don't want to be alone. And the reason you don't want to be alone is because of how it feels when you're alone. So there's nothing wrong with work. Work is great. But work, when you use it to cope, means that there's something beneath that you're running away from. And the thing about running away from things like what Taraj mentioned is that it will always show up in other areas. And this is where the irritability comes from. This is where lack of self-awareness comes from. This is where, transferred aggression comes. You're not dealing with what you need to deal with. It's not acceptable to you, so you avoid it, you run away from it, you run to your work because you are good at that, but you don't know how to handle what it is that is bothering you. So this is how come being a workaholic is a common, but it's an unknown indicator of depression. Substance use. So she mentioned it as well. She said a lot of things, Taraj. So we see people who use substances as though they're weak, as though they're bad. But a lot of times they're just dealing with things, and the substances are like the crutches they use to sustain themselves. So if you want to help someone who is using a crutch, you won't drag away the crutch, you would fix the leg. So that is how substance abuse is an indicator of depression. If you want someone, I'm not saying all substance use, sometimes it's experimentation, sometimes it's something else. I'm just saying sometimes it's, an underlying problem with depression. A lot of times from the patients I've seen, it's actually either depression or anxiety. They take weed to calm their nerves, to sleep, to make them feel confident. They smoke or use cocaine or heroin to help them deal with how they feel about themselves, to help them deal with the emptiness they feel inside. So I'm telling you this as medical people, as people in DMC family, so that when you see someone going through this, I'm hoping it will bring up empathy, and it will make you, empathize with them rather than judge, because they're dealing with something they don't know what to do about, and that's where they see the substances as allies. So you would want to fix the problem rather than say get rid of the substance. And this is why in the treatment of substance use, rehab is key, because in rehab they take away the substance and then they give you therapy to deal with what the thing is that made you use the substance in the first place. So substance use a lot of times is a cry for help. Just the way attempted suicide sometimes is also a cry for help. Impulsivity. So there's something called non-planning impulsivity. This is where you don't have a plan for the future. You're not able to see the consequences of what you're about to do. You're living in the moment, and it's an indicator of depression, because depression typically comes with hopelessness. So you don't even care about the future, come to think of it. You don't care about tomorrow because you don't even think, maybe you don't think you deserve to be alive tomorrow, or you don't see a tomorrow for yourself. So that impulsivity is as a result of how you're feeling, and that is how come it's an indicator of depression. So because depression impairs decision making, motivation, it leads to making rash, impulsive decisions, and that is why depression is an indicator of impulsivity is an indicator of depression. Another common but unknown indicator is weight loss, and then the psychosomatic symptoms I mentioned earlier. So a lot of times as medical people, you see weight loss, you think cancer, you think a chronic underlying illness, you think something else. We hardly think depression, truly. But I'm here to tell you that it actually is one of the common but unknown indicators of depression. So yes, go ahead and look for cancer, go ahead and look for some underlying, system problem. But if you don't find anything, consider depression. So I actually have a case in mind. An elderly woman just kept losing weight until she lost over 10% of her body weight, and then we became alarmed. And we did all the tumor marker screening, we did all the colonoscopy, fecal occult blood, ovarian scan, look for tumors everywhere, and we found nothing. Until, it occurred to us to look for depression, and yes, she was depressed. So in elderly people, weight loss, psychosomatic symptoms are more common, but not just in the elderly, in everyone. Like the patient I told you I saw yesterday, she wasn't elderly, she's in her mid-40s, and I've even seen someone younger than that with psychosomatic symptoms. He is 27 and had psychosomatic symptoms and took medications from neurologists and other people until it dawned on the neurologists themselves, because they were the ones that referred him, that this is not a neurological problem, this is a psychological problem. So, and especially, I started off by explaining that sometimes, or research has shown that Africans somatize as a result of psychological problems more than Westerners do. And the way I explain it is this. Imagine getting married and you get to the altar all dressed up as the bride or the groom, and then your spouse-to-be doesn't show up. A lot of people might experience heaviness in the chest, lump in your throat. Some people will not be able to breathe. They'll virtually be ventilating. So this is a transforming of an emotional pain into something physical. Chest pain, lump in your throat. You can do the chest x-rays and you can do the laryngoscopy, you won't find anything. It is an emotional symptom that has converted itself to physical symptoms. So everyone to some extent is able to transfer or convert emotional symptoms to physical, some to a higher degree than others. And the ones that do it to a higher degree are the ones that end up having these functional neurological disorders. Feeling overwhelmed is also another common but unknown indicator of depression. And she mentioned it, the lady you were listening to earlier on. So again, low motivation, low energy, difficulty making decisions. So feeling overwhelmed is as a result of all that. And this is the reason why people tend to want to run away from what they're going through, but don't really address what it is that they're going through because they fear that they can't cope with it. So it can also be attributed to stress and anxiety. Right, so I've been talking about common indicators but unknown indicators of depression. So what should we do? What are we going to do about all this? So for any symptom that cripples your ability to function, and this is where self-awareness comes in, because we talked about high-functioning depression, where you can basically meet demands, you can basically, meet deadlines and meet responsibilities. So you need to be self-aware and realize that you're struggling with something. And as long as you have that realization, then you need to get help. It could be therapy, it could be medication, it could be psychiatric help, it could be both of them. So in conclusion, depression, as we all know, is a serious mental health illness, comes with high morbidity, reduced quality of life, but its diagnosis can be missed because it has a chameleon-like presentation, and the symptoms may be attributed to something entirely different. So these symptoms can be atypical and difficult to recognize. So being aware of these symptoms that I've mentioned would help you to be able to recognize depression, even if it's going on in yourself or in a colleague, so that we will diagnose promptly, ensure treatment, and prevent unnecessary suffering. Thank you.